Well, we might give it a couple minutes, but thank you for all of you that have joined us already. My name is Brandon Elggren. I'm the national sales rep for the West for EnteroTrack. Have the pleasure of joining Dr. Ray Firszt. Practices out of the Tanner Clinic in Salt Lake City, Utah, allergist. He's been kind enough to do this webinar for us tonight and has a lot of good experience with the tests. So with that said, I'll turn it over to you, Dr. Firszt.
Do we want to wait a few more minutes or do we want to just get started?
Yeah, let's just go ahead and get started.
Okay, great. Thank you. So yeah, I'm Dr. Firszt, Ray Firszt. I'm out in Salt Lake City, Utah at the Tanner Clinic. I've been in practice for 14 years. The first 7 years was out of the University of Utah, and then the last 7 years has been at Tanner Clinic. I finished residency about in 2011. And at the time, not much was known about EoE. It's interesting how it has evolved over the last 14 years. And when I was at the University of Utah, then we didn't know much about EoE. It was kind of a newer disease. We were just starting to become familiar with it. There was a lot of research starting to be developed into EoE. And then during my latter years at the University of Utah, we formed an EoE clinic in partnership with the GI team there, and I'm an allergist, as well as psychiatry and dietitians, and we did that for a number of years until I moved over to private practice. I have served as a primary investigator in a number of clinical trials in EoE, particularly the crossing study most recently, and Messina. Also, I've had a number of publications in this field. And, you know, when we first started treating EoE, a lot of the momentum to treat that was particularly on the food allergy side and trying to identify foods that were causative of EoE or, you know, or problematic. And what was happening was we would recommend, as you might know, and we still kind of do, is like a 6-food elimination diet, elemental diet. And then we try to figure out which of those foods are actually causing the disease. And it was quite problematic, and it's still problematic, because to really identify the foods, you would take 6 foods out, and then you would slowly add a food back in, and then you'd have to rebiopsy. And, you know, when we were first starting in the EoE clinic, it wasn't unusual for us to have 6 to 10 biopsies in some patients in a year, and these were pediatric patients, which obviously, as all of you are aware, is not an easy thing to do. You have to have general anesthesia. There's risks of the biopsies. And so clearly there was a big need to identify a biomarker of this condition. And there's been a lot of research into that. And I'm excited to present on this because it's in my opinion, this is going to really change how we can monitor EoE. And so, yeah, I'm excited to talk about EnteroTrack and the esophageal string test. I do want to say I have no conflict of interest. I don't make any money from them selling this string test. I've been using it now for 4 to 5 months in clinical practice. I've done about 40 to 50 of these string tests so far. And so if there's, I want to try to make this presentation somewhat interactive. So if there's questions or whatever that come up, please go ahead and ask it, and I'll stop the presentation. I can see the questions come through, and I'll try to address them. So I'll move on. So EnteroTrack is the company, and it's called the Esophageal String Test, or EST. And that's kind of what it looks like over here. It's a little blue capsule with a string attached to it. So I will move on to the next slide. So these are an example of the sizes of the capsules. The first capsule is not one that is available commercially yet. That is going to be being studied for other purposes and not for EoE. This is the size of the adult capsule that is used for EoE, and there is actually a pediatric size capsule. And the capsule sizes correlate with the length of the string. So for adult sizes, the string is long enough to span the entire esophagus, and it goes actually into the stomach as well. And the pediatric capsules are smaller, but they also come with a smaller string attached to it. It's also important to note while we're on the slide that the adult capsule is made of gelatin. So if there's a gelatin allergy or a religious issue or concern of consuming gelatin, you may want to let your patients know. The pediatric capsule, as of now, is only available as a vegetarian cellulose. And so it does not at the moment contain any gelatin. Just to go over the slide here, you can see the picture of a female, and that's exactly what it looks like. So once they swallow the capsule goes down, you hold on to the string, and then you kind of tape the end of the string to their face, and they'll sit there for an hour. And it's very easy to do. And I've done it in as young as 6-year-olds who've actually done it very well at doing the string test, to adults. I'll be truthful and honest here. Not everyone has been successful, particularly if they have a very sensitive gag reflex. It can be difficult. There are some sort of requirements of not eating for 2 hours prior to the test, no drinking for an hour before, prior to the test, just to minimize any chance of vomiting or contamination of the string. And if there's no other question, I'll move on to the next slide. This is a sample report. So once we remove the string and we put it in their solution, we'll send it off to EnteroTrack, and they'll send us a report. And the report usually comes back about a week later. It's been pretty quick. On the report, I'll just go through it. It has the lab director's name, their email address, if there's questions, their fax number, and then this will have the patient's identifiers. This is obviously not a real patient. When the collection date was, when they received it in the lab, and then physician was that ordered it. And then this is where the value is, right? So it comes up with what's called an EoE score. And the EoE score will be from anywhere from 0, theoretically, to 1.0. And what that means is it's a probability that EoE is present. And by EoE, the definition that we use is greater than 15 peak eosinophils per high power field, which is what is standard in the EoE treatment community. And so the reference range that the company has validated this test for is that if the score comes below 0.53, then that correlates with a sample that is less than 15 EOs per high power field equivalent in that patient, meaning a normal or inactive state. If the probability is above 0.53, then that is a positive score and indicates active EoE disease in that patient. It is true that the higher the score, the higher the amount of eosinophils in that biopsy is present. But to date, they have not correlated the score with the number of EOs, meaning a 1.0 score doesn't mean that there's greater than 100 EOs per se. That being said, I've had a number of patients come back with an EoE score of 1.0, and it's suffice it to say that that is probably a much more active situation or much more active EoE than somebody who comes back with likely a score of 0.6. You can track these scores and I've done that already in patients who've come back for a second or third string test after I've made modifications to their treatments. For example, I've had a patient who came in and we put them, we got a baseline score. They haven't had a biopsy in a year or two. They were not on any treatment, and we did the string test, and their score came back at 0.7, indicating active disease. I then put that patient on budesonide, repeated the string, and I just actually got the score on this patient back the other day, which came back at 0.52. So it's inactive. It's still kind of borderline, but it's only been a month of budesonide. So my assumption is that if I kept this patient on budesonide probably a little bit longer, that the score would continue to drop. I do think, can numbing spray help reduce the gas? So there is a question. Thank you. That's a great question. I don't think it works, the numbing spray. I've tried it on a patient that had a lot of trouble with the string test, and the numbing spray didn't do anything. That patient also, we did the adult capsules and we did the pediatric capsules, thinking that it would be smaller and it would be better tolerated, but they didn't tolerate the pediatric capsules very well either. And it's important to note that the pediatric capsule is made of vegetarian cellulose. Please correct me if I'm wrong. But it dissolves in your mouth, and it actually creates a little bit of, if you keep it in your mouth, it's going to start to foam, the capsule. So it actually is a little bit harder to swallow, in my opinion, than the adult capsules, which do not kind of dissolve in your mouth. And a lot of kids and adults will kind of hold the capsule in their mouth for a while. And if it starts to dissolve, it just becomes impossible to swallow. So, if the kids can swallow, I found it easier just to use adult capsules, even in pediatric patients, and I haven't seen any issues with them. So hopefully that answers your question, but numbing spray, in my experience, hasn't made a difference. But we also did it at the moment of starting the string test. And so certainly maybe if you applied it a little bit earlier, maybe it would have worked. I'll move on to the next slide. Okay, so this is just going over the process. So they can drink water to help swallow the capsule. My opinion is, and I've practiced myself, is swallow the capsule without water. I find it easier. And then if you need some water to help, help swallow the capsule further, then you can take some water to help. But I would wait until you actually swallow the capsule to drink water. Now, some people do say that water does help them swallow the capsule. So you can try both methods, but I often find that it's difficult to swallow the capsule and drink water at the same time. It kind of makes a little bit of a mess, to be honest. So once they swallow the capsule, you want to definitely secure. So you want to hold the end of the string, which is wound around the capsule, and then they'll swallow it while they still hold the string. And once they swallow it and it goes down, the first few minutes kind of feel a little weird. They can probably feel the capsule a little bit in their esophagus. They can feel the string. But after a few minutes, it kind of goes away and they kind of get desensitized to that feeling. And you just tape the end of the string to their cheek and you just have them sit there for an hour. And they're kind of bored. It's kind of easy. And once the hour is done, you simply pull out the string. The capsule will have dissolved. So all that's left is a string. You pull out the string, and what we do is we lay the string on a table or and you have to try to identify where the junction between the esophagus is and the stomach. And it comes with a little pH stick, and you just try to mark the string, and the string will change colors when you go from the esophagus to the stomach. And then once you get to that, once you identify that segment, it's really easy to do. You literally cut the string at that level because you don't want to send them the stomach part of the string. And then you put it in the container that contains a buffer, and you literally just ship it off. And the company makes it easy for you. They send you these shipping containers, and you just send it off with FedEx, and then you get a report in about a week. These are just some quotes from patients. You know, you can read them. I can tell you that I haven't had anybody that's been, you know, upset about the test. They all kind of love it, to be honest, because it's so much cheaper than going through the scope. You know, it takes about an hour. There's no sort of pain at all. They literally walk out the clinic and they go about their day. And so it really is truly a biomarker that in the sense that it's a non-invasive way to monitor the activity of the EoE that's present there. So I will move on to this insight. There's more insights. This is just also some other, so I'm at Tanner Clinic. These are a number of other sort of centers that have adopted the eosinophil string test, and I can tell you that it's growing. More and more centers are coming on board and are seeing the value of doing this. It's so much cheaper for them to identify EoE rather than going through the scope, and the scheduling of doing this is so easy. I can tell you logistically in my office, if I saw a patient, even, you know, for the first time, and I had a capsule in my office and they haven't eaten for 2 hours, I can literally just set it up within 5 minutes and do the test. It is that easy. It is that simple to do. It's not time consuming at all. If you're a physician trying to figure out how to sort of manage this in a busy clinic, it really isn't a big deal. The clinical utility case study. So this is just a sample case from the company. MM is a 16-year-old male with initial symptoms of dysphagia, trouble swallowing, worse with chicken who had associated regurgitation, nausea symptoms, and then underwent a scope in January 23 with visual findings of EoE and 20 to 25 EOs per high power field in the distal, mid, and proximal esophagus, so consistent with the diagnosis of EoE. He was started on high dose PPI for 2 months. Symptoms didn't improve. And so instead of going for another scope, this patient underwent an esophageal string test. And then the result came back with active EoE score, suggesting that the high dose PPI wasn't enough. You can argue why this patient wasn't placed on budesonide, but went straight to Dupixent. Reality is I probably wouldn't be successful at getting somebody on Dupixent right away without putting them on budesonide, but somehow they were put on Dupixent and resolution of the symptoms, and underwent another eosinophil string test after treatment with Dupixent weekly for 5 months. Here's their scores. So it's showing a 1 probability. As I mentioned, that's the highest score you can probably get. Highest probability, suggesting pretty active disease. I don't see the results of the string test after Dupixent. I'm assuming it was a better score. But that's how you can use the sort of the string test in clinical practice. Here's another case study of an 11-year-old male with chronic EoE, diagnosed at 2 years of age. Food elimination, this is not unusual, slow to do food trials and reintroduce foods because of the need for sedated endoscopies. And I mentioned that at the beginning of my talk, that in the past we would do 6 to 10 biopsies a year as we would do these food trials, which in retrospect, in my opinion, is very intense and aggressive and not something that I recommend doing anymore. OSH recommendation, only fruits and veggies in 2016. I don't know what OSH means, so I will just skip that. But all fruits and vegetables, rice, So it sounds like he's been going through some food challenges and food trials with biopsies and showing which foods he's passed, which is rice, potatoes, coconut. This is not unusual. It sounds like a pretty severe case with lots of food eliminations, reintroducing 1 to 2 foods per year with sedated scopes. And then since October 2022, using the string test, it's showing that he was able to introduce many more foods much more aggressively because of the less invasive monitoring. So this makes sense to me, and it actually brings utilizing dietary approach back into the fold a little bit more realistically, because you're now able to do these string tests very easily with virtually no risk, and you could identify which are the foods that are triggering their EoE with much less invasive monitoring. So that's one of the beauties of the string test, is that it allows us to offer, in my opinion, really offer dietary approaches to this again, and not just medical approaches if the patient is desiring to go down the dietary road. This is just out of their one of their papers, their published publications in the Journal of Pediatric and Gastroenterology, but it's again kind of going through 3 situations. In case A, the patient had 6 endoscopies in 6 years. The EoE was well controlled. The patient was avoiding dairy, wheat, and egg and corn. They then added corn, but instead of proceeding with EGDs, now they underwent the esophageal string test, and they got an EoE score of 0.414, which I showed you earlier was less than 0.53, indicating inactive disease. And so that patient then, you would say that patient, had a successful reintroduction to corn. And then what they did after was introduced wheat, and again, did that for some period of time. And then unfortunately, on the second string after that, had an EoE score of 0.68, which would suggest that that was an active situation. And so went back to avoiding wheat, and then tried to add dairy and came back with an EoE score of 0.325, which suggests inactive disease. So this patient was successfully able to reintroduce corn and dairy in their diet, and identified wheat as still as an ongoing trigger in their EoE. And pretty easy to do. And like I mentioned, avoided having to do all these scopes and cost and risk associated with them. I do see another question, so I'll ask that. Since missing accurate number count and visualized now are the best used. So this, so it's another good question. Thank you, Sarah, again. So this is not meant to be diagnostic. It's meant for monitoring patients with EoE. So my recommendations and the formal recommendations of utilizing this test is in patients with an existing diagnosis of EoE, and sort of monitoring it. It's not really meant to diagnose it. You can use it, like I've done it, as an initial screen in patients, where the scope was, going to be a long while to get. I had to send them to GI, and I had the string here, and they were interested in just screening for it. But I would still get the scope, whether it was positive or negative, especially if there's symptoms there, just to confirm the diagnosis and see how visually it looks, and if it looks really bad. And so, but it's very useful in monitoring it, as you can imagine. Hopefully that answers your question. I'll move on to case B. Again, 7 EGDs in the preceding 7 years, most with active EoE. So this is a patient with an initial biopsy report prior to the string of active disease with 28 EOs per high power field in the distal esophagus, 82 EOs per high power field in the proximal esophagus. It wasn't on any treatment at the time, got placed on presumably high dose PPIs, and then underwent a string test for monitoring the treatment intervention. and then so the EoE score in this situation came back as 1, so very active disease. And the patient was on omeprazole 20 milligrams twice a day. So clearly not enough treatment. And so a topical steroid like budesonide was added, and then underwent another string test, and the EoE score came back at 0.848, suggesting that the fluticasone spray was not enough. So they increased the dose of the fluticasone from 440 twice a day to 880 twice a day, and their EoE score was still active, but getting better. And this is a way you can kind of monitor that the steroids are helping, but maybe it's not enough, or maybe you have to wait a little bit longer. It can take a few months for the steroids to work. And so if you repeated the string maybe a little bit later, that score would continue to come down. And I would probably correlate whether you would do anything in this situation with how long this intervention was, how long this interval was, excuse me, and also the clinical symptoms of the patient. Because if the patient's doing well here and the scores were coming down, and maybe this was only a month apart, I would say, well, let's maybe restring them in a few more months rather than actively changing course at the moment, because that EoE score over the next few more months might continue to come down. It can take a while for the inflammation in some situations to go down. And then I'll go down to the last case here with 8 EGDs in the preceding 8 years with waxing and waning EoE activity. Prior to the first string test, their distal esophagus showed 10 EOs, proximal esophagus was 0 EOs. The patient was on 320 milligrams of inhaled seclesinide twice a day and was avoiding wheat. So here's a patient who's on 2 interventions. One is medical, one is diet, with EoE that's well controlled. The patient then added wheat into their diet. And so the intervention was a dietary approach, and then the patient underwent a string test and unfortunately scored a 1.0, suggesting reactivation of their EoE. And so unfortunately, wheat does not seem, wheat was probably triggering it. So instead of taking wheat out of the diet, they increased the seclesinide dose to 640 micrograms twice a day to see if the steroid alone, without removing wheat from their diet, would control their EoE. And in that situation, it seemed to work. So this is probably a patient that doesn't want to avoid foods and would rather treat their EoE medically with medicines. And this was a successful approach at treating their EoE with inhaled seclesinide and using the string test to tailor the dose of the medication to make sure that it's treated properly. There's another question here. I will go ahead and since EoE can cause difficulty swallowing, how often are you finding that the string test fails for that reason? So what I would say is, if a patient, the preliminary data in this study, or most recent data for using the string test, is that it can identify 93 to 95% accuracy. It's 93 to 95% accurate in diagnosing EoE. So it's not 100%, right? And so if a patient comes in and the patient has symptoms and you're worried that the patient has EoE, and you do the string test and the string test comes back negative, at that point, I would probably recommend an endoscopy in that patient. There could be a few reasons for that. First of all, the patient could have some symptoms because they have heartburn. They could have a stricture there that needs to be dilated without evidence of active disease. So if the patient needs to get dilated, the string can't do that. It can't visualize any strictures. But what it can tell you is if there's active eosinophilic inflammation there. So if you're in doubt, or if the patient has symptoms and the test comes back negative, I think in that situation, I would recommend that the patient gets an endoscopy because it could both be therapeutic if they need to be dilated, and it could also come out with some alternative diagnoses that might be present, or unfortunately, it's not 100% the string test. So it can miss it. And so, it might miss the disease, and that's, in a few percentages of patients. So I think that answers the question. The other way I might interpret that question is, patients with EoE, do they have trouble swallowing the capsule? I haven't seen it yet, but certainly I could imagine a situation where there was a proximal stricture that the patient may not be able to swallow the capsule. But most of my patients have been able to do it. The ones that have failed because of their EoE was not because they were really unable to swallow the capsule. It was more because of their gag reflex being too strong, and we couldn't overcome it, and they just wouldn't swallow the capsule. So, but not because of their dysphagia. I've not had a patient fail the string test because they had choked on the capsule. This is just an example of all the updated partners that are incorporating the string test. So it's growing across the country. Here in Utah, Intermountain Healthcare is one of the biggest healthcare facilities in our state. And I imagine these will continue to grow. This has the email address. So if there's any questions that you have, especially logistically, or how to incorporate this into your practice, or if you want some of the sales reps to come and visit with you, I would reach out to them. They're very responsive. They're great. And this is their website. On their website's great because they have a video that goes through the process of it. Again, like I said, it's very easy. It can kind of feel a little overwhelming and weird at the beginning, but once you do it once, it's really simple to do. I do have another question. What does scheduling patients look like? For me, most of the time I'll schedule the patients in advance. So if I know they want to do the string test, I work with my nurse who will schedule them, and we can do them pretty much every half an hour. I leave about a half an hour for them because some of them do have trouble swallowing the capsules, but you can probably do a string test every half an hour and kind of find a place to monitor them for the hour that they need to keep the string down. You can also do it on the spot. If you have a capsule there and they haven't eaten any food or had any liquids in the past hour, you can proceed with the string test right there and then. It's so easy to do. Some patients will swallow the capsule in like 30 seconds. And like I've even had kids that did it so well and much better than adults. So I wouldn't be afraid to try it on pediatric patients. That's all I have. I'll wait around a little bit more if there's questions. Hopefully this was helpful and informative. But I'm so excited about this because I've been truly waiting for a biomarker for EoE for the past 5-10 years. And we've had things that work okay, like blood eosinophil counts and blood eosinophil cationic proteins, but those are systemic signals and they're not localized to the esophagus and they're not entirely accurate. So this is truly the first way we can non-invasively monitor this condition, and I'm truly thankful for it coming to market. I do have a few more questions. So patient feedback, I showed that on a previous slide. I can go back to it. In my experience, it's been really good. Most of my patients have already gone through a second or third string test just because we've made some interventions on the first, on the previous string test. So these are doctors, but here's one. It's just so positive, the feedback that we get from the patients because of how quick it is to do it. The kids are back at school. If we do it, we'll often do it first thing in the morning or early in the morning because they're kind of fasting, and they're back at school within an hour. Once you pull the string out, the patients can leave. You have to do like I said, you have to cut the string at the end of the GE junction on the string. which is easy to do, but they don't have to wait around for that. They don't have to wait around for you to fill out all the labels. They can just take off. They won't have any symptoms. They'll feel great. It's, yeah. I'll move on to another question. Can see why would you do the initial string then scope? Certainly for monitoring, great option. Related, not, do you scope using transnasal? I don't scope anybody. I'm an allergist. There is a gastroenterologist at our children's hospital that does transnasal endoscopies, and those are great as well. They definitely don't have to use general anesthetics in that situation. So transnasal endoscopies is fantastic option. And they're supposed to be very accurate and as good as the usual route. And then, yes, it can improve access, but you're still limited by having the scope person being available to do the transnasals is not completely user-friendly. It's not like the GI doctor that was at our children's hospital had to get trained on how to do the transnasal endoscopies. So it wasn't something that just any GI doctor can pick up. I'm not 100% sure it's going to lower the cost that much. Maybe the anesthetic cost, the anesthesiologist cost, but certainly the facility fees, and they're still undergoing the endoscopy. I really don't think it's going to affect the cost dramatically by doing transnasal scopes. But yeah, if my kid needed to get an endoscopy and transnasal was an option and they can dilate using transnasal, certainly, that is an option. I don't know that I understand the first question. Can see why you would do initial string then scope. So maybe you can clarify that question. I'm not, or maybe it's not a question at all, Sarah, but yeah, I mean, I've done string tests initially as a screener, but I've also sent patients in for endoscopies too, to get a more accurate picture. And again, this is mainly used, it's not for diagnostic purposes. It's used for monitoring. I'll wait around, I guess, a few more minutes. If there's questions, they're still coming in, I guess. Okay, thank you, Sarah. She was just mentioning that it wasn't a question. So, Brandon or Seth, do you want me to wait around for more questions or?
I think this was great. Thanks everybody for jumping on. Thanks, Dr. Firszt, for doing the webinar. It's been, super informative and we got a lot of good questions here. I don't see anything else coming in, so please reach out to us if you have further questions. Info at enterotrack.com, the email, and we'll get back to you. Would love to see this in your clinic. But thanks everybody for jumping on here.
Thank you all.